Hey everybody, my name is Eric Norman and welcome to the Mettle podcast. I'm a physical therapist and shortly I'll be joined by my partner in podcasting, Christian Jorns, who is also a physical therapist. And today we're going to do a little bit different. We're going to be doing some questions back and forth, and we each have 4 questions for each of us, and hopefully it won't take too long to get through them all. We had some really good discussion and went on some good points, so I'm super excited for all you listeners to listen to this one, and as always, hopefully get 1 or 2 good things to take away from it. And if any of you have any questions, want to reach out, discuss different options for things like programming, please do. So thanks again, everyone, for listening, and we'll see you later. Hey, Christian, what's going on, man?
Hey man, things are pretty good. Glad you picked Monday night at after dinner hours to record this thing.
Hey, schedules are getting hectic nowadays.
You've had some vacations. You're at the Dells every
I know.
weekend.
I just take the time that's given to me to get away a little bit, you know? I just got back from up north visiting family and friends, and then just got back a little bit ago. But it's nice to be back home, get some stuff ready for work tomorrow, and looking forward to our conversation tonight and what it has in store. But what have you been up to lately?
I'm on full dog sitting duty. Victoria's away back at home in Chicago. She was there for like
Nice,
5 days, comes back tomorrow. So I've just been working with him, running, swimming, all that kind of stuff.
nice. How did his paw do? Or have you been training with him? Have
Yeah,
you been
yeah.
doing stuff?
His paw ended up being fine. We did run that 5K
Nice,
and it went super
nice,
well. It was a very chill environment, so we didn't go fast at all. But overall, it was a great time. There was a bunch of events afterwards, like a dog lookalike contest, which Victoria and Bruiser won. And then I later went and did
nice.
like musical chairs with him, and we did not do so well.
That's funny. That's funny. Right on, man. Nice. So if I remember right, that was kind of like your last race until maybe one next year with them. What are you doing nowadays in terms of training? You still doing endurance stuff, or are you switching it up?
Oh, I'm still doing endurance. I'm biasing endurance moving forward, but I'm still between running programs right now, so I'm just maintaining my mileage while also trying
Nice.
to dip my toes into some sprinting, which is something I haven't done since I was a kid, basically. But like, I want to feel what it's like to go, however fast a 34-year-old can go. So I'll be doing some of that soon. But then I got my lifting going again. I'm doing the power lifts basically 3 days a week, so less than I'm used to. I'll be doing that for the next couple months, focusing on my deadlift and overhead press. I'm going to give the bench press a little bit of a break.
Nice. There you go.
Yeah, what's your
I
training
like
like?
the overhead press. Yeah, pretty similar to what your last little bit was there. I know a couple weeks ago I talked about getting back into getting onto that barbell a little bit more, getting some more weight on me doing squats and whatnot. And it's been going well. And I've been doing transitioning from higher repetitions, and now I'm getting it down to like sets of 4 or 5 and starting to get up there and weight again, which feels really good. And it's coming along pretty well, but just have to keep getting after it. It's always about that consistency, like we talk about. So, but yeah, nothing too crazy for me. Just a lot of that leg exercises and just trying to maintain upper body really. And as I'm trying to get back into those heavier weights for the squats and deadlifts. So anyways, well, like you heard in the intro, we're talking about some kind of questions back and forth between Christian and I tonight. We're going to discuss, it's kind of PT in general PT questions. It's not going to be anything specific like, Christian, what do you think about this, clinical practice guideline? We're going to be talking more broad strokes when it comes to physical therapy, and hopefully, it should be an interesting podcast, I think. So I'm looking forward to get going here. So, Christian, if you don't mind, I'd like to start out with the first question I have for you. What are your initial points of emphasis if a patient is not improving with a current plan of care?
Yeah, I like this question a lot. There are many things, but I chose 3 things I want to talk about now. So number 1 is we should reevaluate. Number 2 is what have they been doing lately? And 3, have we been going into pain or to the verge? So for reevaluate, maybe I just made a mistake with the diagnosis and now we need to find a different one and pivot our plan. Or maybe I'm just missing something that would be helpful that I didn't get on that first interaction. And doing a formal reevaluation makes me take a more focused look. And then I may have just been missing a pain referral pattern or some other glaring issue at a different part of the body that could be contributing to the problem. So number two, what have they been doing lately? This one's huge. So let's say they're feeling beat up or worse from the exercises that I gave them, and they've been doing them daily. Maybe we need to go to every other day or just cut back on that volume to allow for more rest. There's so many times where that's just the answer. Maybe they have only one of their exercises targeting the sore area, and we get the sense that it might not be enough. I'll add another exercise and see what happens over the next couple weeks. Now, maybe their exercises aren't quite targeting the sore area at all, and we feel like it would be better if we could tap into that painful spot better. We might change their exercises altogether or just fine-tune the angles or the loading that we use for them to make them more targeted. And number three, have we been going into pain or to the verge? Now, Derek Miles from Barbell Medicine has a really good short quote on this. He says, you can train through the pain or around it. Pick one. So for someone in a lot of acute pain from a recent ankle sprain, you're going to train around the pain or to the verge of it as your first choice almost every time. This is because you know the tissue was recently damaged. It's clearly healing if it's swollen and it's stiff or whatever. You know that pain is a way for your body to tell you that something could be potentially damaging, and you know that overstressing healing tissue is a great way for more pain. So really, you aren't going to try to go into pain for these folks. Now, for someone with long-standing tennis elbow, you're probably going to train or be okay with training into some pain. And I hear this one a lot where people have been doing some exercises they found online or got from someone else, but they haven't been getting the results that they're looking for. They've been doing the exercises, going through the motions, but usually with little to no weight, and they've not been progressively adding more weight over time. So now, while this method might work for some people, by and large, sore tendons need to be loaded heavy. There's some foreshadowing there, I think. And you're more likely to get results from a plan that goes a little into pain than one that completely avoids it, although that's not a hard rule. I'll end with this. One thing to add from the research here is that most chronic musculoskeletal pain, it doesn't really matter if you train into the pain or on the verge. Both methods work equally well over about the same time frame. Now, in the real world, one of those methods tends to feel better and work better for most people, and that's the one that I choose as a start whenever I can.
I really like that last point you added with the chronic pain, because unfortunately, that's a lot that we see in clinic. At least where I work at in our clinic, unfortunately we have a lot of individuals that get referred to us for pain that they might not have something like fibromyalgia or something, something more intense, but maybe just had low back pain for the last 12 years, right? So I like that point. I think that's a good point to add.
All right, so my turn for a question. What's one thing that you do in physical therapy that you feel exceptionally passionate about?
Yeah. I know it says one, but it's hard just to narrow it down to one. So I'm gonna go off the rails a little bit. I won't get too far into each one, but when it comes to rehab stuff in specific, I used to play a whole lot of baseball growing up, and even after high school, still played some amateur baseball. And so I really have a passion for baseball. And unfortunately, we can get a lot of throwing injuries in the, shoulder, elbow, wrist, or hand, unfortunately. And so primarily that shoulder and that elbow region is really common for those throwing injuries. And so I really like working with athletes, throwers, in particular, baseball, softball, just because that's my background. And so I feel like I excel more in that. But yeah, I think I actually I had an individual who was a Frisbee golf player, and he was having problems with his right arm that he throws with. And that was really interesting because it was a different mechanic than what throwing a baseball is, or throwing a softball. So that was really cool. I would say top one when it comes to a rehab concept. Throwing rehab is my number one for most passionate. But just in general, though, I really am passionate about mental health and just improving health in general when it comes to my patients. Unfortunately, I see this too often that individuals think that it's like it's their fault that they're having this pain. You know, they talk about, oh, I need to lose all this weight. It's my fault. I'm too heavy. Or, I did X, Y, or Z that caused this to happen. And, I think it's really important to help people out through that so they don't feel really just guilty about it. So in a more broad strokes, I guess, helping individuals with things like mental health or just improving health in general. I think PTs, we have such an important spot entry point would be a good way to look at it when it comes to improving health, just because we know that more movement, more active lifestyle can really help out with a lot of different comorbidities. And so that's been something that I've been finding a lot of joy with in practice, is just helping individuals understand and live a healthier lifestyle.
Yeah, that's all fantastic. If I had one thing that I was passionate about, it would be kind of going off of your point about just getting people healthier. It would just be getting everyone to lift. Like, you don't need a power lift. You don't
Yeah.
need to do CrossFit. Just 2 times a week, pick up some weights, put them back down. That would be so awesome for your health
Yeah.
and my
Right
mental
on.
health.
No, I like that. Yeah. Yeah. Moving weight. It's kind of crazy. You go into the gym, at least this is, going back to our training updates, right? It's like you can be having a negative day after the clinic and then you get under some heavy weight and just for some reason problems don't seem so big anymore. And so it's a valid point that you bring up. All right. My next one for you. In general, how do you approach initial evaluations when a patient first comes into the clinic?
Yeah, I think I do this pretty classically, like we're trained in school, with subjective, objective assessment, all those kinds of components. I've just lengthened the conversation part of my initial evaluations over time, since I find it's usually the most helpful for me, but also the patient, so they can say their piece. And my interview style is heavily based on motivational interviewing. And that, now, for those that don't know, motivational interviewing is a style of conversation that's often used in medicine and therapy and even business. It's characterized by empathy, compassion, asking open-ended questions, and summarizing what the patient says to demonstrate that you're listening and making sense of what they're saying. Now, going back to the structure, the shell of my evaluations, I follow a simple like talk, test, talk flow. So for talk number one, the first thing I say is, tell me the story about this pain. That open-ended question alone tends to take care of a lot of the other questions that I wanted to ask anyways. So after the story and a bunch of back and forth questions that we'll have, we go on to some testing. Based on that first talking bit, I have a list of potential diagnoses or things that could be going on, and I select tests to look for and or rule out those things. So then I go on to talk number two. This is where I combine the information from our conversation and the tests into a narrative. It often starts with, so this is what I think is going on, and then I'll lay out my thoughts about their diagnosis, and I'll often explain other possibilities that I was thinking about that just didn't really pan out and give them my reasons for that. Then next, I'll describe how this condition usually plays out and then what we can do about it. And that's where I go into their treatment options like exercises, dosage of them. Do we need a referral to a doctor for more information? Would it be helpful to have more imaging? Are injections useful? All those kinds of questions. Then from there, we just work together to make a plan. And I'll close with 99% of the time, at least, I give them exercises or movements to start working on day one because I want them to leave with something actionable.
I like that. I really like that last part. Kind of goes off what we were talking about from your first question to me about if there's one thing you could do is just get people lifting or moving, right? And so I think that's really great. The other thing I wanted to hone in on a little bit before we move on is that motivational interviewing piece. Like I just think that's awesome that you structure around that. And that's how you like to lead your subjective portion. I would also say that I have a very similar evaluation style, and I wonder where I get it from. For those of you who don't know, Christian was my clinical instructor in PT school. But anyways, no, I really like that. I had a motivational interviewing course in undergrad, and I told my professor there when I came back, I said, I wish we could just take your course and put it in PT school, because it is such a great course and it's so valuable to what we do. So I think that's great that you use that a lot in your initial assessments.
All right. Question number 2. What are some general concepts that you think about when helping someone learn a new movement?
Yeah, I really like this question because it got me thinking more about what are the big things that I think about when I teach people new movements. And the first one is educating them on the goal of the movement, right? Especially when it comes to pain or their diagnosis that they're in for. I think having a purpose behind it rather than just showing them something, have them do it without, someone asks them, why are you doing this squat motion? Well, I don't know. My PT just gave it to me. Versus telling them why they're doing it. I think that's really important. So educating on the goal of the movement. The next one, I really don't like to get too into the weeds with the movements unless I have like a power lifter or, an athlete that's in there or an active individual that just really likes to lift and they're very familiar with the movement. And then we can get into the weeds on some things. But for the most part, if it's just general population and I'm trying to teach them, a squat, let's say, a lot of times individuals will ask, am I doing this right? Should this be like this? Should this be like that? And sometimes I think we can just get so bogged down in those details when it comes to teaching a movement like the squat. So I try not to get too much into that versus just having it look good and feel good. And off of that, I'll leave it with, I try and limit my initial teaching cues to just 1 or 2 things. So that when individuals go home, rather than having 5 different things they're trying to work on with it, they just have 1 or 2 cues that they can take with them. And I found that tends to be a lot more beneficial. Again, if it's like a power lifter that comes in, we're probably going to get a little bit more into the weeds on things. But for the most part, I like to keep it pretty broad stroke and really educate on the goal of said movement.
Yeah, so many people get bogged down in the details, and the best kind of coaching is the stuff that's very simple, very clear. You may, as a therapist, have 4 or 5 things that you see could be improved to make this movement better for someone or make them more proficient at it, but you can't give them all those details at once. So what becomes a fun game for us is figuring out what's one thing I could say to them to check as many of those boxes as possible. So I'm always looking for fun cues like that just to make everything so much more streamlined.
Yep.
And I love that you mentioned that you are very clear and intentional about what's the goal of these movements with your patients. Too many times people are like, oh, I've been doing my exercises. Like, what do you mean my exercises? Like, are these, like, what's the point of them? Are they trying to like get you stronger somewhere? Are they trying to help you with this painful movement? Whatever it is, like we got to have a plan for this stuff.
Right. Yeah. And the last thing I just want to bring up on that, because the thought just popped into my head. A couple of times I've had patients go, do you just sit at home and think of these exercises in your laboratory? And I always tell them like, hey, these aren't my exercises. Like I didn't come up with these. These have been here for a while. Everyone uses them. So yeah, I think that's funny how you said like my exercises, and it's true. It's like it's not our exercises. We didn't come up with these. Like they've been there, and we know what works and what targets things best. So, anyways, last little plug on that one. So, all right, my next question for you. What are your favorite analogies to use with patients?
Gosh, there are so many that I hear all the time in the clinic. I think my favorite one of all time that I don't use anymore is motion is lotion. For some reason, I just feel weird saying that. It just feels kind of campy to me, so I can't be brought to say it, but I do love hearing it. But I do have a metaphor that I use for pain sensitization. And this is one for people that are dealing with what's called nociplastic pain, which is pain that happens when your danger detectors and your pain processing parts of your brain are on high alert. Your danger detectors, which are actually called nociceptors, can work just like a dumb smoke detector. Normally, smoke detectors only go off to the right amount of smoke, like an actual fire, we hope. Sometimes, though, they go off every single time you try to cook something over medium heat. Our job is to figure out what your body needs and how much of it to get that smoke detector recalibrated so it only goes off to the stuff that actually matters.
I really like that. That's awesome. I don't really have anything in terms of clinical stuff to back that up. I just think it's really cool. I love that analogy. I'm going to start using that. I haven't heard that one. But I'm just laughing because my smoke detector in my kitchen, if I just turn on the oven and then open that thing up to put some, I don't know, whatever I'm baking that day, that thing goes off automatically. So yeah, I know what you mean when the medium heat stuff comes into play. So yeah, no, I really like that. I think that's great.
All right, question number 3, Eric. Light weights or heavy weights for tendon pain?
Oh, man, I'm going to try not to get canceled on this one. These dang tendon debates and rehab and training online and the different discussion platforms, it's like, can we just chill out for a second and take a deep breath? No, honestly, for me, it depends, but I lean heavier relative to the patient, right? When I'm working with a patient, if the pain is allowing heavier loading in that area, so if we're just looking at like the elbow, for example, if that elbow is going to tolerate, or if that tendon in the elbow is going to tolerate the weight that we're doing, and if we can increase that, and then I want to try and get heavier with that. I also like to think about pushing into something called reps in reserve, right? So it's a way of thinking in terms of your repetitions per set. When you're using a certain weight, you want to think about doing that until you think to yourself, gosh, I could only do like 3 more of these and I'm going to fail that 4th rep. Or 2 reps in reserve, or 5 reps in reserve, whatever it is. You can pick a number for it. I like to do usually like 2 or 3. So that's what I like to do. I lean heavier on the tendon rehab, and I also like to push more into that reps in reserve versus just a set number of repetitions per patient.
Yeah, that was kind of my foreshadowing earlier. I actually didn't know
Yeah.
all your thoughts on that, and I'm sure you have tons more. But yeah, it's a contentious topic in our industry, but I think we're all settling kind of in the middle where it's like, yeah, heavy is really good. Seems to be probably the best if you had to pick one, but there's a ton of people that get better not using super heavy weights, maybe like at the 4 or 5 reps in reserve instead of 1, 2, or 3.
Yeah. Yeah, and I agree with that. And another thing, that I also like in terms of just the heavier weights too, is I feel like it gives the patient confidence. You know, if you're able to do a heavy resistance and the pain isn't getting worse, and I've found, mentally individuals start to feel more confident with their pain and diagnosis. And I think that positivity only bodes well for them, in future sessions. So,
My only other pitch for heavier weights is simply time. When you do a bunch of lighter weight training, and we do have some evidence for this in the calf, there's a protocol. I think it's called the Alfredson protocol. It's crazy
mhm.
high volumes of calf raises every single day. So you can get better doing that probably, or you can do like 3 or 4 sets of like 8 to 12 or something 3 times per week. Like which one which one sounds better to you?
Yeah, right. Yep, exactly. Exactly. I agree. Good old Alfredson's protocol. I didn't know you were gonna bring that one out today. That one went way back. All right. So last question I have for you. For a patient in pain, one piece of advice to give them, just kind of for general purposes. What's piece of advice to give a patient in pain?
Yeah, so this made me think about, I think the most important thing for patients, or one thing that I feel passionately about, aside from everyone needing to lift, is that people need their expectations set. People in physical therapy know they're not dying. They're in PT. but they would like some idea of when this is going to get better and what they should do about it. So for anyone that's in pain right now, here's my blanket advice. Your pain will get better, and it'll probably get better all on its own. Your body is already doing all the heavy lifting in the background. We're here to help guide you and your body through that process so the pain will hopefully go away faster and it won't come back easily. The best plan is the one that's right for you right now, and that plan needs to evolve with you over time as your experience with your pain changes or your goals change. And then we're going to do everything we can to make sure that happens. And if we don't get a handle on this pain in the next 1 to 2 months, we have some other options that we can use to bolster that effort. Now, I say something like that to my patients mainly because it accomplishes several things. It reassures them that they're going to be okay and that I'm going to do what I can to help them. And then if we aren't able to do this on our own, I have these other people I can refer you to for extra information and help. The bottom line is we always have a plan. We always have a contingency plan and a bunch of other plans after that. And I feel that this helps them feel more comfortable about the process since they have an idea of how things can play out. Because when you don't know what's going to happen, your mind just goes in crazy places.
Absolutely. Yep. It's a good point for, I think, just general life stuff, right? Just in general. I mean, if you're a homeowner, if you have kids or something, if you don't know a plan or if you don't know something going forward, you start to think of all these different things that could go on, how it all could play out, and trying to get a hold on your pain and what your diagnosis is no different. So.
Yep. All right, last question for me. Favorite YouTuber for rehab or training?
Ooh, that's a good question. I'm gonna settle on Greg Lehman for mine. E3 Rehab comes to mind as well. I really like their stuff. And then I think you even mentioned Barbell Medicine earlier too. I really like their stuff as well. But I'm gonna go with Greg Lehman just because I think that the things that he puts out on YouTube from what I've watched and learned from him, I've even had patients go and listen to some of his videos because they're so simple and tangible things that you can use right away or comprehend right away. And that's why I really like the stuff that he puts out. Not to mention, and I know that Barbell Medicine and E3 Rehab, they do a great job making sure that all their stuff is backed with the literature and making it very research based. But I also think that Greg Lehman does a lot of really good scouring of the research to make sure what he's presenting is really what's being shown and in this research. And so I really like what he has to say. And for anyone that maybe you heard the first podcast on ACL stuff. I already name dropped him before because he gives some good advice. And so for anyone who hasn't listened to him, Greg Lehman, physiotherapist out of Canada.
Yeah, I'll second him. I think he's fantastic. Mainly, for me at least, mainly in his message delivery. He says things very differently than you're used to hearing. It's not clinical. It's very down to earth, which I think is useful for everyone, whereas only some people find like that really didactic, like research heavy stuff to be just kind of difficult to follow or just kind of played out, annoying. Greg Lehman is like always there with really good lines.
Yep, I agree. Awesome. Well, that's all we got for questions tonight. We just picked 4 each, and I think we got a lot of really great content out of that. Hopefully, listeners, all of you did as well. One thing out of the 4 questions that I asked you, Christian, what's one thing that you would want to emphasize the most to the listeners?
Yeah, Eric. So going back to, I think it's your first question where you asked me what were the initial points of emphasis when someone's not improving in your current plan of care. I think a big one to highlight is just like for any folks who are dealing with some pain on their own, ask yourself, what have you been doing lately? If you've been doing the same thing for many, many months and you got this ache, whatever's going on, try doing that thing that you like to do a little bit differently. Change the weights you're using or change the style of running you're doing. Do fewer days in the week. Give your body some more rest. Move differently. at least for a portion of your week. Usually when you mix things up a bit, at least for 1 to 3 months, a lot of things start to clear up. Your body begins to heal from all that continuous use while you're stressing other parts of those same tissues. And when you do that kind of blended approach over the course of a year or 2 years, you end up being far less hurt, far less often.
Yeah.
But I'll put that one back to you then, Eric. What's one thing that you want to emphasize from what you said?
Yeah. Yeah, absolutely. My biggest thing is for individuals out there dealing with pain, especially if it's chronic pain, don't just throw away or dismiss the mental health side of things. And when I say mental health, I'm not saying that you have severe depression or something like that, right? It can be as simple as, like I said before, having this guilt. Maybe it's just a low level guilt around your pain and feeling bad about it, right? And knowing that it's not your fault and that you didn't knowingly cause this pain to come on. And look at therapy and rehab as more of we're trying to improve not just this pain, but also hopefully get stuff to improve your health in general. And so don't dismiss the mental health side of things. It can play such a big role in our rehab process, but also how you as a patient or client or whatever it might be, how you are processing and how that nervous system behind the scenes is dealing with said pain. So, and lastly, I'm just going to throw it out there again. Go check out Greg Lehman if you haven't, because I think he's great. So thanks everyone for listening, and we'll be back next week with some podcast. Not sure what it'll be yet. We got to decide.